Good afternoon, everyone. My name is Cora Peck. I'm joined today by Dr. Warren Mackie-Jenkins, who is an anesthesiologist and interventional pain management specialist. He practices in Woodbridge, Virginia at Nova Orthopedic and Spine Care. Thank you, Dr. Mackie-Jenkins, for joining us today to tell us a little information about the DRG neurostimulator and how it can be used for pelvic pain, such as pudendal neuralgia. So welcome.
Thank you, Cora. Really appreciate you setting this up. I think it's super important, what you're doing in terms of your advocacy work and how we're trying to educate folks on what options are out there to try to manage chronic pelvic pain, in particular pudendal neuralgia, because not a lot of folks treat it, not a lot of folks know about it. And I think the more information that we can get out to the public, the better it will be for patient outcomes in terms of knowing what treatments are available and what might be helpful.
Absolutely. I totally agree. Well, let's first start with what is the DRG stimulator and how does it work?
Great question. Not a lot of people have heard of DRG stimulation, know what it is, know how it works. And it in the medical community too, to be quite honest with you, sometimes we don't actually know how a lot of these things work. But there's a solid research basis behind DRG stimulation. It was originally developed a number of years ago for the treatment of something called complex regional pain syndrome. And so DRG stimulation is on label for treatment of complex regional pain syndrome type 1 and type 2. What is complex regional pain syndrome? It's a neuropathic pain condition that's characterized by severe, persistent neuropathic pain, which is like that burning, tingling, electric shock-like pain that often affects the limbs. But what we have learned over the years is that there's a role for DRG stimulation in terms of treating chronic pelvic pain, in particular pudendal neuralgia and other neuropathic pain conditions that can affect both men and women in the pelvic area. And pelvic pain has a lot of similarities and characteristics to complex regional pain syndrome. Numbness, tingling, burning pain, electric pain, severe persistent pain that is really quite intractable. And so we have started, probably over the last 5+ years to treat pelvic pain with DRG stimulation, and there have been pretty remarkable outcomes. And I know we'll get into that a little more throughout the talk today. But we have sort of extrapolated the use of DRG stimulation to chronic pelvic pain, which often has a lot of the characteristics of complex regional pain syndrome, for which the DRG stimulator was developed.
That's great. And can you show everyone what the device looks like and then
Yes.
explain its components and kind of
Yes.
where they go?
Yeah, I think that the best way to start talking about that is how do we do DRG stimulation? And it's a little bit of an involved process, which can sometimes be very confusing and overwhelming for patients, especially when we first start talking about this treatment modality. And so the way that we take patients through sort of the journey of DRG stimulation is in three parts. And the first part is a little bit of a nuisance, but it's a necessary step in that before we even talk about doing a DRG stimulator, if we've talked about it and want to go ahead with the process, patients have to get a psychological evaluation. And it's mostly an insurance requirement that is, in my opinion, a little archaic, but patients are required, even with conventional spinal cord stimulation for low back pain, for example, patients are required to undergo a psychological evaluation. It's essentially screening for two things. Number one, that you don't have an untreated substance use disorder, which may interfere with outcomes with the device. And number two, that you don't have any untreated severe mental health disorders that may interfere with your ability to tolerate or to take care of yourself or to maximize the therapy. And so those are sort of the two things that we're looking for, the psychological evaluation is looking for. And I try to make it as easy for patients as I can in my practice, and I use a telehealth company, and it's done from home. And as soon as that gets out of the way, we proceed with what's called a trial. And the trial is done in office, or sometimes in a surgery center with anesthesia. And the electrodes are actually placed, believe it or not, in your spinal column, where the DRG or the dorsal root ganglion resides. And the idea behind certain chronic pain conditions is that they are mediated through the dorsal root ganglion, which is a component of the spinal nerve. And the input, the painful input is all pain is transmitted through nerves. And a lot of the nerves in the periphery, for example, in the pelvis or in the lower extremities, converge in what's called the dorsal root ganglion. And that is a component of, again, the spinal nerve. And we place an electrode in very close proximity to the dorsal root ganglion as it exits the spinal canal in what's called the neural foramen. And so this is always sort of a difficult thing to conceptualize. Well, if I have pelvic pain, why are you putting an electrode, in my spine? That doesn't make sense. And the idea is that anatomically, that is where the nerve input converges and transmits that pain signal from the periphery to your brain. And so we intercept those pain signals at the level of the dorsal root ganglion before they travel to your brain. And there are a lot of theories behind how this works, and that may be a little out of the scope of our conversation today. But from a pure mechanical standpoint, we place an electrode under live X-ray guidance in the area anatomically where the dorsal root ganglion resides. And I will do my best to show this here. So this is what the electrode looks like. There are 4 little contacts on there. You can hopefully see
Yes.
the 4 little pieces of metal. And it's tiny. It's hard to appreciate, I think, on Zoom, but it's a very, very tiny electrode, and it's no bigger almost than my fingernail. And that electrode, we very carefully place in the neural foramen, and it resides there for the duration of the trial. And then ultimately, if the trial is successful, for the implant. And so that's what the electrode looks like. Place my hand here, so hopefully you can see a little
Yep.
better. And then that electrode, and typically for trials, we place 2 electrodes unilaterally, meaning either on the right or the left. And most patients with pelvic pain tend to have bilateral symptoms. But the trial itself is looking to just establish as a proof of concept, does stimulation of your dorsal root ganglia, does that provide at least 50% reduction in your pain and symptoms for which we're doing the trial? And so those electrodes are then connected to a temporary battery, which is all external and taped to your back. And this is what the temporary battery looks like. So it's a little bigger, about the size of the palm of my hand, if you can see that. But that is just temporary. That remains in place for about 5 to 7 days. And if the trial is successful, then we proceed to an implant. And the implant is all tunneled underneath your skin. So we make a couple of tiny incisions where the electrodes are buried and anchored underneath your skin. And then the wires from the electrodes are tunneled underneath the skin to a permanent or semi-permanent battery, which is also buried underneath your skin. And this is what the battery looks like right here. So it's about the size of like the top of like a Coke can, for example. And it's about a centimeter thick, or maybe a quarter, a third of an inch thick. So hopefully you can see it well there in both from the front and the side. And then the battery and electrodes for the implant are all placed again underneath the skin and the subcutaneous tissue. So most patients, at least in my experience, don't even know that the battery's there, and we take a lot of care when we place the permanent device to place it in an area that's not going to rub up against your hip or other structures in your back. And we tunnel it pretty about a centimeter deep. So again, most patients don't really know or aren't bothered by it.
Does the battery ever lean against other nerves by any chance, like the
It does
sciatic?
not.
It does not.
No, it is nowhere near the sciatic nerve. Sometimes people do have a little discomfort from the battery, and that usually occurs if the battery is too close, to example, to some of the bones in your pelvis. And when I place these devices, I take a lot of care in marking patients and having patients, tell me, does the location that I want to put the battery, does that feel good? Is that out of the way of your belt line, for example? Do you feel like you'd be able to reach back there and touch it, for example? And so we do take really quite a bit of care to place the battery in a place that's not bothersome. But it
And
is not near any nerves, not near the sciatic nerve or anything like that. But the electrodes, again, are in the spinal canal. So they're near, your spinal nerves.
right. And you mentioned the trial.
Yes.
Um, what you mentioned if it's successful, what's deemed as successful?
So by criteria, a successful trial is defined as at least 50% reduction in pain.
Okay.
And that's a very subjective measure. For folks who live with chronic pain, it's oftentimes really hard to tell, is this 50%? Is this 60%? Is it 100% is pretty rare, but sometimes we do see that. So I always tell patients, we're gonna 50% is the magic number. But what I want you to tell me is, did you feel better? Did you feel like this enhance your quality of life? Did some functional metrics, for example, patients with chronic pelvic pain often have a very difficult time sitting for long periods. Riding in the car is something that's really difficult. Sex is really difficult. Now, we don't recommend having sex during the trial because everything is sort of temporarily in place. And so physical activity can cause the temporary electrodes to migrate, which we don't want during the trial. But things that we look at are like quality of sleep. Did you find that you were sleeping more? Were you waking up less with pain? Were you more bothered throughout the day? Was going to the bathroom less painful? So there's some functional metrics that we look at in addition to that absolute reduction of 50% in pain.
And remind me one more time, how long is the trial?
The trial is usually between 5 to 7 days. I don't do trials any longer than 7 days because the longer of, sort of an externalized foreign body stays in place, the higher risk you are for developing an infection. So I generally do my trial somewhere between 5 to 7 days.
Okay. And is the procedure itself painful?
The trial itself can be a little uncomfortable. We anesthetize the skin and some of the subcutaneous tissues. But we are putting a needle in your back, and sometimes that can cause a little bit of discomfort, especially after the trial, after the local anesthetic wears off. But the trial itself is not, I mean, I have not gone through a trial myself, so I can't speak to how painful it is. But the feedback that I get from patients is that it's not terribly uncomfortable. And I often do these trials under some sort of sedation to try to make it as comfortable as possible. But there's a little discomfort for the first day or so after we do the trial, just because of where we have to place the needles to actually get the electrodes in place.
And for the permanent one, is there any difference in?
There is, because we make incisions to bury the electrodes and to anchor the electrodes into place, and we also make an incision that's about 2 inches wide to create a pocket for the battery, and that does cause a little discomfort for about a week or so after the implant is placed. But after about a week or so, I would say most patients have very little discomfort after a permanent implant is placed.
And you mentioned for restrictions with the trial, you said sex is definitely a no. Are there any other restrictions that you suggest to patients?
Yeah. So because everything is externalized and taped to your back, you cannot shower for the duration of the trial. And I'm okay with patient sponge bathing as long as you don't get the dressings wet. Because if the dressings get wet, it could disrupt some of the electrical components of the temporary trial system. And it could cause the dressing to come off and for the electrodes to come out, which would sort of negate the purpose of the trial. Other restrictions that I impose are bending, twisting, and lifting. I don't want patients bending over. I don't want patients sort of twisting their back because everything is temporarily in place. And then I also put a 5 to 10 pound lifting restriction on patients for the duration of the trial. But I do want patients to walk. I want patients to be as active as you can be with the restrictions of the trial, so we can know if it's going to be a helpful therapy for you.
Okay. And with the permanent implant, do you have any additional restrictions with that?
So the same restrictions remain in place for the first week. And then I always see patients a week after I do the implant and I take the dressings off. So the dressings stay on, clean and dry for 1 week. And then same restrictions. So no showering, sponge bathing is okay. No bending, twisting, or lifting more than 5 pounds for the first week. And then when I see patients in clinic for the first post-op visit, which is a week after I do the implant, I take the dressings off in clinic. And if the incisions look like they're healing well, there's no sign of infection, everything is progressing positively, then I slowly remove restrictions and liberalize the bending, twisting, and lifting, and then allow patients to shower after the first week.
Okay.
I do also put a submerging in water restriction. So pools, bathtubs, hot tubs, those sort of things. I don't want patients to submerge in water for 2 months after the permanent implant. The reason for that is so that everything can heal. One of the more concerning risks of a permanent implant, especially when there's foreign metal body, is that it gets infected. And fortunately, that happens pretty rarely, but if it does, we almost universally have to remove the device.
Okay. And for the DRG, are there any risks associated with getting the implant?
Yes. Anytime we do any procedure, there are inherent risks. And those risk factors, we go over very carefully with our patients. The biggest risk, I would say, is that the device gets infected. And that doesn't happen very often, less than 5% of the time. But if it does get infected, if it's a superficial infection, sometimes we can treat that with antibiotics. If it's a deeper infection, we have to remove the device. So that's a risk that I counsel patients on very carefully, and we do some things to try to prevent some of those or mitigate some of those risk factors. Bleeding around the spinal cord is another risk, albeit very rare. So we carefully look at your medical history, assess if you're on blood thinners or have any risk factors for bleeding. Infection around the spinal cord or the spinal nerves is a risk, although also very rare. Damage to nerves and other tissues is a risk with the permanent implant and with the trial. Again, we take a lot of care and use modern techniques, including live X-ray guidance. I use neuromonitoring for the permanent implant, which is a way to enhance the safety of the procedure. It is a very, very safe procedure, but there are risks with anything. And so procedurally, those are sort of the big three. Occasionally patients, when we do both the trial and the implant, can develop a CSF leak, and that's if the needle that we use to place the electrodes inadvertently pokes a hole in the sac that surrounds the spinal cord. And that could cause fluid to leak, which is usually causes a self-limiting headache. Very rarely do we have to intervene on a CSF headache. And there are certain procedures that we can do and medications that we can prescribe to help if that occurs. And that occurs very rarely, again, because we use modern techniques with live X-ray guidance. That I've never had a CSF leak from one of these types of procedures. So very rare, never life-threatening, but sometimes can cause a pretty nasty headache for a week.
Okay.
Other risks after the implant is in place include inefficacy of therapy. And what that means is that you've had a successful trial, and then we put the implant in, and then the therapy doesn't work, which is really unfortunate, but does happen. And we don't really understand why that happens, but it does happen. If that's the case, we try to sort of program the device, try different types of programming to optimize the therapy. Ultimately, if the device is not providing adequate pain relief, we can explant it and take the device out. And so that does happen sometimes. And the trial is sort of the best tool that we have to assess whether or not this therapy is going to work for you. But like anything in treating chronic pain, there's no guarantee that it's going to work for everyone. So that is a risk that I always want my patients to be well aware of, and we try to optimize the trial, but sometimes does happen. Sometimes the leads will fracture, meaning and I usually see this after like a motor vehicle collision or some sort of trauma. And in patients who are very, very active, the leads are at risk of fracture and migration, meaning that they move out of place. The technique for DRG stimulation has improved a lot, I think, over the last 5 years. And the anchoring techniques that we use have significantly reduced the risk of lead fracture and lead migration. Back 5 years ago, before we were anchoring, there was about an 8% risk of lead fracture. And with anchoring, that's now somewhere around 2%. So it's gone down significantly, but does happen still.
And I remember you saying so the stim can be removed. Is there a certain time frame that you guys put on that? Like, do you give it like 3 months, 6 months to see if the programs change, or is there
Yeah,
other restrictions you have on that?
it's there's no sort of, I would say, formal method to this, but generally the approach that I take is if we put the device in and we've given it 6 months and we've tried to reprogram it and adjust the programming, and we've of course verified with imaging that the leads are in the right place, but it's just not providing pain relief. What I do is turn the device off for a month. So we will remove the therapy. And sometimes patients will come back and say, actually, this was helping a lot more than I thought. I don't want to have it taken out. But sometimes patients will come back and say, I've had the device off for a month. I don't feel any different. And so I like to give it a solid month without therapy, because the last thing that we would want to do is remove a device that was helping, and then have a patient come back and say this was actually helping a lot. I think we sort of jumped the gun, so to speak, on removing it. So I always give like a 1 month holiday from sedation before we decide to I'm sorry, a 1 month holiday from stimulation before we decide to explant.
And I know we've kind of talked about it, but how do you decide if a patient is a candidate for a DRG? I know we touched on it a little bit. Is it, do you try certain things first before you get to that point?
Yeah,
Like
absolutely.
patient.
And yeah, patient selection, I think, is absolutely crucial for successful DRG stimulation. And so we look for patients who have refractory, intractable, severe pain, and really needs to have a neuropathic component to it for DRG stimulation to be successful. And what I mean by neuropathic component is that burning, tingling, electric-like pain. Patients who have sort of musculoskeletal pain, kind of like a muscle ache, tend to not do very well with DRG stimulation. And then I also, and universally this is true, we want to see that patients have failed conservative management. And conservative management is a pretty broad concept. And so I want patients, especially with chronic pelvic pain, to have at least tried somewhere between 6 to 8 weeks of pelvic floor PT, perhaps, other types of therapy, to have tried any number of medications, including muscle relaxants, neuropathic pain medications like gabapentin, Lyrica, Cymbalta, non-steroidal medications, all kinds of medications. And then at least some sort of interventional therapy, be it a nerve block, or like a vaginal wall trigger point injection, or a ganglion of implar block, some sort of conservative therapy that we can prove that this really hasn't helped before we talk about something a little more invasive like a DRG stimulator.
Okay. And is age a factor by any chance?
Uh, Yes and no. So one of the things that we do have to assess is, can we physically safely do this procedure? And one of the things that I look for, and every patient who we do a DRG trial in needs to have some sort of imaging of their spine. If it's a CT scan, or an MRI. And what we know with age is that degeneration affects the spine more progressively with age. And so sometimes that neuroforamen where we want to put the electrode is more narrowed the older that we get. And if it reaches a certain level of stenosis or narrowing, we cannot safely do the procedure. And that stenosis or narrowing does affect us the older that we get. So age, I would not say is an absolute, contraindication or, would preclude someone from undergoing this trial, but rather the degree of stenosis that we see on the MRI that would preclude safely doing the procedure. And so sometimes young people have severe stenosis in their spine in the area where we want to put the electrode, and that would preclude the procedure in a young person. And then sometimes older patients have wide open neuroforamen and really good anatomic targets. So it all depends on sort of the patient.
Okay. And in your personal experience, have you found the DRG stimulators to be helpful for pelvic pain?
I have. I haven't done a lot for pelvic pain because it's it's a fairly rare condition. And I would say of you, probably the half dozen or dozen or so that I've done, we see pretty good results. Now that doesn't look like, and again, expectations I think are really, really important here. A device is not the right answer for everyone. It is perhaps the right answer for someone who has gone through years of treatment and isn't making any progress and has really severe pain that is interfering with their life. And that's often the case for patients with chronic pelvic pain, who've seen any number of specialists, haven't gotten answers, and we don't always have the answers, but sometimes we do have the tools to try to manage symptoms. And that's where I think expectations are really crucial. Someone who will not do well with a DRG stimulator, someone who has the expectation that this tool is going to make you 100% pain-free 100% of the time.
Yeah.
And so it comes down to patient selection and patient expectations. If we can give you 50% relief to the extent that you could get back to doing some things that you enjoy, for example, sex, for example, activity, and understanding that it's not going to make you pain-free forever, I think that those are patients who tend to do really well.
Okay. And then I actually had one more question. So when you put, I forgot to ask it, sorry. In the beginning, when you put the leads in, does it change, for instance, with someone with like pelvic pain, where you put the leads compared to someone that might have back pain or a different reason? So for like
Yeah.
pudendal neuralgia,
Yep.
would you put it in a specific location?
Yes, that's a great question. And I just had this conversation with a patient this week who I'm going to do a trial for chronic pelvic pain and pudendal neuralgia. And we used to put electrodes in the S2 and S3 neural foramen. S3 is off-label. But what we found is that there's a significantly higher risk, the further down that we get into the sacral foramen, of lead migration and lead fracture. And so most of us who are doing these for chronic pelvic pain these days are placing electrodes in the L1 neural foramen, which is much higher up in the spine, but is where the sympathetic nervous system seems to converge. And so we're able to get a lot of coverage of chronic pelvic pain and certain other conditions too, like, for example, an inguinal hernia. We're able to get really good coverage putting electrodes at L1 and S2. So most of us who are doing for pelvic pain these days are putting them in L1 and S2. I don't do S2 and S3 much anymore. I have done it. But that was sort of the classic teaching, because the S2 and the S3 nerve roots are what coalesce into the pudendal nerve. But we find that we tend to get better coverage with L1 and S2. Now, that's much different than, say, someone, for example, who has complex regional pain syndrome of the foot and ankle, where we would put the electrodes at L5 and S1, and then certain other conditions, like, for example, complex regional pain syndrome of the knee, we would put the electrodes at L3 and L4.
Okay.
So we try to place the electrodes anatomically where the pain is coming from.
Okay. Awesome. Well, thank you so much for your time. This was extremely informative, and I hope it'll help anybody who's considering this as an option, to be able to actually see the device and know kind of the process behind it. I appreciate
Yeah.
your time. Thank you so
Absolutely.
much.
One sort of parting note that I would say, there are a lot of pain physicians out there who do a lot of different things. And I think it's extremely important, especially for patients for chronic pelvic pain who are often, overlooked, gaslit sometimes. It's really important to be your own advocate and ask questions. And it's okay to to have doubt. Like, well, if I met someone for the first time who was saying, oh, you need a DRG stimulator, I would probably have questions about that. Like, why do I need to do this? Why are we jumping to this? And so it's an excellent therapy, it's an effective therapy, but it's not the right therapy for everyone at that certain time in their treatment course. And so I think it's so important to advocate for yourself, to ask questions. And any physician you see should be willing to answer those questions and be able to walk you through the thought process behind why he or she is recommending that particular therapy for you. Okay.
Yeah, absolutely.
All right. Thanks so much, Cora. Appreciate it.
Thank you, Dr. Mackie-Jenkins.
Bye bye.
Bye.